Hi, everyone. I'm Dr. Gina Pritchard, and welcome to the BaleDoneen Method with Dr. Gina Pritchard. Today, I couldn't be more excited to have as our guest, if you will, one of the thought leaders and the co-founder of the BaleDoneen Method, Dr. Amy Doneen. So, Dr. Doneen, welcome.
Thank you, Gina. Thank you. I'm very happy to be here.
Thank you for being on and giving us some of your time. Everyone's been asking questions, want to know Dr. Bradley Bale and Dr. Amy Doneen just a little bit better. So today we want to hear about Dr. Doneen's journey and a little bit about her background and understand how this life-changing BaleDoneen method occurred over the past 18 to 20 years, if you will. So let me just start by saying that Dr. Amy Doneen holds 3 professorships. She's an adjunct professor at Texas Tech Health Science Center in Lubbock, Texas. She's a clinical associate professor at Washington State University College of Medicine and assistant professor at the University of Kentucky College of Dentistry. She owns and manages the Heart Attack and Stroke Prevention Center in Spokane, Washington, and she is one of the nation's leaders, thought leaders, a driver of innovation, if you will, not only in preventing heart attacks and strokes, but in particularly focus on women's health and cardiovascular disease prevention. She did indeed co-found the BaleDoneen Method with Dr. Bale in 2001. So we'll talk a little bit more about the method later on for those who perhaps are listening and haven't heard of the BaleDoneen Method. But let's start with you, Dr. Doneen. Tell me a little bit about your pride and joy, your family. All of us, that's number one priority in our life, as much as we love our careers. So let's hear a little bit about your family.
Well, first, thanks for asking. I rarely get to talk about my amazing family, my 100% support system when I talk about my professional life. So, Dr. Pritchard, thank you. I do appreciate that. I am married to a wonderful man. His name is Doneen, and we have been married for 25 years this summer. And he's amazing. All my years of going to school and going back to school and professionally gaining traction and really burning the pavement, if you will, to try to get cardiovascular disease recognized on a national, international scale level from a preventative standpoint. He's been really the silent force behind that, and my respect for his dedication to this topic is second to none. So thank you, Darren, for that. I appreciate you. We have been together since we were children, basically. We met in high school and got married. We have 3 beautiful children. Our oldest, her name is Sydney. She is 22 years old, and she is a college graduate heading to law school. So her focus in law school at this point is going to be educational law. She's a huge proponent for public education and an advocate for that whole world. She's down in San Diego at the moment, but we don't know where she's going to law school, so you have to circle back to me on that one. Okay. So very excited about that for her. Our middle child is amazing. His name is Devin, and he is a junior in college at Western Washington University. He's a wrestler there and going into business and marketing, and he's a really kind, amazing young man. So, and Devin is 20. And our youngest is a senior in high school. We like to say we're quitting high school soon. We only have about a few months left, and she'll be graduating. She wants to go into perhaps, she's the one of the 3 that might go into medicine, heavy on the might. Her focus is orthopedics and orthopedic surgery, thanks to Grey's Anatomy. So we'll see what she wants to do in her world, but really nothing's going to stop her. So she's a real dynamo. Her name is Sophie, and she is 18. So those are my three children and my amazing husband, Darren. And we have a dog named Darby, who's my running partner in the morning, and a little ancient kitty cat who's about 16, we think.
Wow. Yes. Oh, that's great. How wonderful. What a lovely family you do have.
Thank you.
The next thing, speaking of Darby, you have been an inspiration and motivational to thousands, I'm sure, many of us, in terms of your healthy lifestyle. And even a broken leg barely slowed you down. You were still in the gym with the cast on.
I mean, I think that we need to live by example, and I'm fortunate enough to have healthy joints and find running very mindful and energizing for me. And I know not everyone has that luxury. So I'm really, really grateful because I do travel a lot with my work, and I find the ability to just throw in a pair of running shoes allows me to kind of see the country from a new way. So I've always been a runner. I've done marathons for about 20 years now. Boston 3 times. I was there during the bombing, which was a really challenging experience, and basically have been pretty much graced with an injury-free path. Broke my leg a year and a half ago and had to deal with that, but otherwise I'm back on the road, and I'm grateful for that.
Great. Do you have a marathon on the horizon now that the leg is healed or healing?
I do. I don't like to make too many announcements, but I have about 4 big runs planned this year. So
you're back trained.
Rest assured, at 4:30 in the morning, you'll see me out on the pavement somewhere. The only thing I am not good at is the treadmill. I do not do well on the treadmill. So I do like to be out in all the elements, enjoy the sounds. I run without headphones. I want to know what's around me, but yeah, I like to be outside.
Lovely. So even if it's a big snow in Spokane, that doesn't slow you down. You love that kind of running with it.
Out this morning, matter of fact, and it was about 9 degrees and lots of snow and ice, but you just have to be careful and have the right equipment, but it's doable.
I know it was very important to you for your children to pick an athletic endeavor that they enjoyed. Were you athletic, or did your upbringing foster that in you as well? Or that's just something?
I think it did. Our parents were, I would not say athletes, but they always supported us doing some sort of activity. It was easier when we went to high school and that you could just try different things. You don't have to have this one sport passion from the time you're 5 like it is now. It was so much easier then. So I did pretty much everything I could get my hands on, from gymnastics to track to cross country to drill team to cheerleading. Anything I could do, I was all in. I've always felt the more active I am, the more involved I am, the better grades I was going to have. So our kids kind of took on that. And you and I have talked about this study over the years, but when children are asked why they exercise and why they keep themselves healthy, open-ended response from the University of Michigan on just that was they responded because their parents did. So both Darren and I have tried to set examples of how to live healthy, and we're certainly not perfect, but we do try to set good examples. And I'm grateful that our children, all 3 of them, have found kind of life sports and have been able to carry those sports into college and carry them on after college from a more just recreational level, but it's been good for our family.
That's great. So tell me about some of the influencers in your life. Did you know that you wanted to go into the medical field, a nurse, or early on, or what prompted you to go to nursing school?
Yeah, that's a good question. When I first went to college, college wasn't really pushed when I was going to school, actually. I knew I always wanted to go, and I always knew I wanted to go into medicine, but when I was in high school, it was never a thought of, well, go to medical school then. It was never. And when I voiced interest in medicine, the concept was, well, then go to nursing school. And I thought, well, okay, which deeply respect the field of nursing for sure. It created who I am today, and I'm grateful for that. But I look at it now and think, I wonder if things would be different had I chosen a different path, and I don't know. I think what it's done for me, this path that I've been on, is created a strong work ethic and got me to where I am today with a very abbreviated path at different levels. I mean, I started out working my way through college as a nursing assistant. Then I went and got my LPN so I could work nights to get my RN. And then after I got married and we had 3 children, I wanted to go back and have some autonomy. So 6 years after that, I went back to school to get my master's. And I'll circle back to when I met Bradley Bale in that path. And then finally was able to get back to get my doctorate, all of which have been in a nursing field. My doctorate is a Doctor of Nurse Practitioner, and I'm very proud of that. It's actually the first nurse practitioner doctorate to graduate Gonzaga University. So I'm proud of that path. I don't think it was the easiest path, but boy, did I learn along the way. And I've always followed a philosophy, the more I know, the more I don't know. And it just kept me going all this time. So I'm a huge fan of nurse practitioners. I'm a huge fan of education in general. And I think when you think about the globality of cardiovascular disease, Gina, and you think, gosh, why are we still why is it still the #1 cause of death and disability? I think we've made an inappropriate assumption that the disease itself, cardiovascular disease, should be plunked in one category of treatment providers, such as cardiology. And while cardiology has done an amazing job with survival rates, the recidivism rate of this disease and the sheer numbers of people still suffering cardiovascular events is staggering. I heard a colleague of ours, Dr. David Wright, give the analogy of Boeing 747s. And he said, I think the number was 5. So David, I apologize if I'm misquoting you, but I believe he said 5 to 7 fully loaded 747 jumbo jets crashing, everyone on board dying every single day.
Mm-hmm.
Every day, Gina, is what we're dealing with the statistics with cardiovascular disease. So when I think about all of our opportunity to intervene on that, we all have a role, whether you're a family practice medical provider, a family practice nurse practitioner, an RN, a dentist, a hygienist, a cardiologist, a nutritionalist, an exercise physiologist, a psychologist. We all have the role of really nurturing that very fragile patient with thousands of miles of highways to actually intervene and make a difference. So I think we all have a role in that. And that's one of my sort of behind the scenes plight, is to invite everyone to the table. Because I think once everyone's at the table and realize that they have a valuable role in this disease state, we can really make a difference. It's not going to be just us, it's going to be everybody.
For sure. And it's going to take a lot of us.
It is, yeah.
More and more of all varieties of healthcare providers, that's for sure.
That's right.
Said another way, the analogy of the 5 to 7 airplanes going down every day, that is very good. I hadn't heard of that before, but I have heard others comment about the death rate from cardiovascular disease being similar to that on 9/11. So if we had something on the news every night reminding us of the sheer numbers that are not only dying every day, but then it's well beyond that in terms of those that have a stroke or succumb to a life that's completely altered forever due to the disability of stroke, we would really all come together to battle, right? But we just begin to sort of become complacent and think it's an inevitable part of aging, which it definitely is not.
Correct. Yep. Agree.
So that brings us to the BaleDoneen Method. Let me just say that it is the premier, the most powerful and effective heart attack and stroke, diabetes and dementia prevention method. It's a cardiovascular disease treatment and management method with a deep dive, if you will, a heavy focus on prevention. So those that have high risk and have had multiple procedures, let's say bypass surgery, maybe multiple stents, heart failure, can come and go through the BaleDoneen Method and apply the principles to their life and markedly reduce their possibility going back for another procedure, and certainly live free from the fear of having another heart attack or stroke. For those of you who perhaps haven't heard of the BaleDoneen Method, the BaleDoneen Method is an evidence-based, powerful, and effective method for heart attack and stroke prevention, also diabetes and dementia prevention. It's the premier cardiovascular disease management, treatment, and prevention program in the world today. Doctors Bradley Bale and Amy Doneen co-founded the method. So I want to focus just a little bit on the components of the BaleDoneen Method and when the history of the BaleDoneen Method. So how did you and Dr. Bale meet, and when did you begin working together, and how did that sort of morph into where we are today?
Sure. Well, thanks for asking. I worked for a registered nurse for several years while we had the children and they were young. And we actually lived in Montana. And at the time I was doing home health IV infusion therapy, going through all these mountains of Montana. It was really kind of a great experience. But I had this one gentleman who I would have to drive my car up this literally mountain slope and deliver IV infusion for an infection in his lower extremities. And I got to know him and his wife very well. They were very kind. And one day I went up to deliver this, and I usually went on a weekly basis, and other people went at other times. But when I got there, both his legs were amputated. And I remember being just shocked because I realized the terrain for which they were in, and I realized immediately that this elderly couple was now stranded. They had no way to get out or in. He was the main they didn't work anymore, but the main provider for the land. And I remember just the catastrophic crisis of what I just experienced. And that kind of logged in my brain, and I started to think about the idea of vascular disease being so systemic, when we're so focused on organs such as the heart and the brain, which are critically important. But as you and I have discussed over the years, the idea of keeping the systemic highway system healthy is really the ticket here. So if we talk about vascular disease from a systemic standpoint, we remember our poor gentleman up in the woods of Montana who lost both his extremities due to peripheral vascular disease. Peripheral arterial disease rather, and we think about the catastrophic claiming of life of things like dementia and stroke risk, and obviously cardiovascular risk. And immediately the global nature of this disease got my attention. And then we had moved back to Spokane, and I was working at the time in a women's health clinic. And I actually was asked to do work on a in vitro fertilization clinic to create an educational program on a donor egg program. And that was very intriguing to me because I knew nothing about it. I was fortunate enough to not need IVF through pregnancies, and I feel very blessed on our path. Pregnancy path was much easier than a lot of these families that I was dealing with. But what intrigued me is the lack of attention on cardiovascular disease in women. The questions weren't asked of these young women who wanted to donate this life-saving opportunity, and I thought, boy, there's a disconnect here. And at this time we had two of our children. We hadn't had Sophie yet, and we decided we could afford to get me back to school and start my master's, for which I did. And I think that was in the year 1998, maybe. Sophie was born in the year 2000. Right at the end of my master's degree. And as I was going through school and I was thinking about what my thesis work was going to be, I learned of the idea of coronary calcium, which was being done by several people in Spokane, but one family practice provider in particular was using it on his patients and had been for a few years at that point. So I went to him to ask if I could do some clinical work at his office. It happened to be Dr. Bradley Bale. So at that point, it seemed like a pretty easy opportunity to look at these coronary calcium scores and ask, how many people have calcium and normal cardiovascular risk factors? So it was this aha moment that a lot of us are told we're fine, and we're walking around with plaque and have no clue. And he had already had the foresight in his family practice career to say, a lot of people who are told they're normal are having events. What can I do better? And one of his mentors, who I've now come to know over the years, Dr. Paul Shields, was really one of the first to bring that technology to make it accessible to particularly family practice. And I know Brad will tell you more about that. But anyway, that's kind of how we met. And as we continued to work together, we realized that philosophically, we were really on the same page as far as prevention. And then in about the year 2000, carotid intima media thickness testing came to the table. By now I had gotten my nurse practitioner license, and we worked together in the clinic basically. And when carotid IMT came to the platform and was backed actually by the American Heart Association in the year 2000 to be safe, reliable, reproducible, here's a technology that not only could you find disease that was non-calcified, but you could use this technology to follow the disease over time. So it was a very exciting moment. And so I remember very specifically, I think it was the year 2001, right in there. I'm a little bit sketchy. Between 2001, 2002, Brad and I were at a conference, and we were sitting in the back row, and we were listening, and we were like, what about? And they were talking about cardiovascular disease treatment, different mechanisms, and we were saying, well, what about inflammation? What about, these other causes, insulin resistance. And we started to etch out, and I still wish I had it, and maybe I still wonder if I could find it, on a napkin, what is now become the BaleDoneen Method. So we started to chunk out these little elements. And so from there, it launched into what it is. And we just had never parted ways since about the year 2000. And both feverishly learning as much as we can, as quickly as we learn it, try to share it, because there's others much smarter than us who are going to hear this and help us really get this as well. And you have to be vulnerable to appreciate the magnitude of what you're doing. And what we decided is that we wanted to share this information as quickly as we saw clinically that it was working. As we were doing repeat IMTs in the clinic, we thought, my gosh, this is actually making a change in these individuals' biology. And all of a sudden we thought, well, our patients are not having events anymore. And so that kind of was the start of the formality of the BaleDoneen Method, if you will. Brad moved down to Lubbock, Texas in around 2005, 2006, I believe, right in there. And I stayed in Spokane. We were raising our kids, and Darren and I didn't want to move. And I was able to take over the practice at that point and change it to what it is now. But that's kind of the nuts and bolts of the beginning stages of where we were. And then we started to formalize the CME BaleDoneen Preceptorship Program in 2007.
Mm-hmm. So tell us a little bit, I want to talk more about the preceptorship in a minute, but you mentioned that the BaleDoneen Method has a positive effect on the artery wall. And of course, we have the tools now, the technology to be able to track that and actually see before our very eyes the artery wall becoming healthier and the life-saving effect of all of the interventions throughout the year with the BaleDoneen Method. But we also have 2 studies that have been published demonstrating not only decrease in inflammation, but regression or arresting and stabilization of that vulnerable plaque. Would you just tell our audience a little bit about those 2 studies?
Oh, sure. And thanks for asking. So the first one was actually both were out of the Spokane clinic. And the first one had 576 patients. And it really was a grassroots campaign, and that exactly what you said. We were seeing improvement. And one of the things that we don't want is to have optimistic bias. So at the time we had a partnership and preceptor academic appointments, I should say, at Texas Tech, University Health Science School of Nursing. And a tremendous amount of individuals, incredibly supportive, and a great biostatistician department. At any rate, we approached them to say, would they help us analyze our data? So ultimately blinded 576 patients who we'd been following for about 8 years, turned it over to Texas Tech and said, are you seeing what we think you're seeing? And ultimately, at the end of that trial, what they were able to do, Dr. Du Feng, F-E-N-G, created a latent growth curve analysis, which means we were able to go back retrospectively and see what sort of change happened over time using the carotid artery, carotid intima media thickness results to validate improvement or worsening, if you will. What we found was a definite linear improvement in the average thickness of the artery wall, and a linear improvement of both the plaque volume and also the plaque activity, as documented by a very strong biomarker called lipoprotein-associated phospholipase A2. So that was really the first trial that said, okay, the BaleDoneen Method is, or I should say, has been demonstrated to identify, stabilize, and regress atherosclerosis. Mm-hmm. We were very excited about that. And then a couple years later, Dr. Stephen Jones was analyzing that data, and he is and was at the time the chief preventative cardiologist at Johns Hopkins. Mm-hmm. And he said, well, this is very exciting. And did you happen to look at the lipid richness of the plaque? And at the time, I didn't know if we had enough data to actually evaluate the lipid richness because the technology for which to do that had improved over time as far as reproducibility. Bottom line, we had enough data in 324 patients followed over 5 years to show that. And what we showed in that trial was that we could remove the lipid-rich core of the plaque in 100% of those patients within a 5-year time period, with the biggest change in the first year. So the reason that's such a big deal is because it has now since been proven prospectively that it is indeed the lipid-rich core of the plaque that is the most predictive, validated through other technologies that we don't have easy access to, like MRI, infrared spectrometry, and all of these more advanced opportunities to validate what we were able to show clinically. So we have these great trial sets to show, yeah, this actually works. It's feasible. It's cost effective. It definitely takes a partnership between the provider and the patient. That's for sure. And so part of BaleDoneen is science, and part of BaleDoneen is the art of delivering that science. Because when you talk about prevention, ultimately what we're trying to do is treat something that we hope our patient never feels. And that is not easy, because it's not like patients are coming in saying they have back pain, fix me, or I have a sinus infection, fix me. They don't feel they even have a problem. And therein lies the challenge of applying prevention to somebody who feels great already. And we're going to make sure that we ensure they stay that way over time.
Mm-hmm. You know, as the healthcare consumer, if you will, all of our listeners, you and I, everyone really, becomes more and more educated. The conversations are changing around the water cooler at work, the cocktail parties, etc. Everyone is interested in objective measures, right? Of, am I getting healthier, or am I missing something? Am I not? And we know it's far more than just looking in the mirror and seeing how fit you look, or even getting on a scale, etc. But I have even noticed, and I think it's exciting, and this is due to the BaleDoneen Method, that more and more of these conversations are turning away from things like, well, did you pass your stress test this year, or how did you do on your latest cholesterol panel? These things are have a place. How's your blood pressure? Certainly, you know, it's a key indicator. But there are far more effective and valuable biometrics to know about our health. And there are objective ways to sort of look inside the body and see these things that you've just talked about. So tell us a little bit about what you would like to have people ask you or talk about if they didn't know you were Doneen at a party when they were talking about their health. What would, if the conversation of biohacking came up, tell us the maybe top 3 or 4, since we've been talking about arterial health, things that if these 3 or 4 things you knew about your health as compared to maybe last year, you could know that we're getting healthier and preventing heart attack or stroke from invading your life.
Excellent. One of them is, you know, genetics have become so accessible to the healthcare consumer now, whether they be direct to consumer reports where you can take a swab of your cheek and send it in and you get all kinds of information. One of the things I like to say is we have a knowledge of genetics now in clinical practice that we can be extremely precise in our treatment recommendations, both for identification of lifetime risk and also allowing us to understand how best to offer treatment, whether that be through diet recommendations or through something called pharmacogenetics to avoid side effects. So what might be best for me might not be best for you based on how we metabolize different medications in our body. So I think I love the conversation of genetics, and I want people to think it's more than just understanding where your ancestors are from. But we have this valuable tool with genetics, which are now so cost affordable. It's a one and done. It's not like people have to repeat it. So these are not thousands and thousands of dollars. These are, you know, pennies on the lifespan, if you will, to understand who should be screened more thoroughly. How should your treatment be prescribed? Because there's no panacea diet for anybody. There's no one size fits all for any of us. So genetics is one. The other that I want people to start being comfortable with is the word inflammation, and not just this nebulous sort of idea, but really there are cost-effective ways to know, are our highway systems safe or are they not? And these tests are so accessible. It used to be that they had to be ordered from a specialty lab and insurance wouldn't cover them, and they seemed to be out of reach, or at least a perceived out of reach for most people. And indeed, that platform has changed as well. The challenge we have, Gina, is that the world of insurance, medical insurance, has not caught up to where we are with our science and knowledge of prevention. And somehow, some way along that journey, the healthcare consumer and the medical consumer, like the physician, somehow uses insurance as a default scientific filter on what has clinical merit or not. And what I challenge clinicians to do every day is to use the science as your decision maker, and don't underestimate someone's predisposed value and investment in their own health. If something isn't covered by their insurance, tell them how much it costs, tell them the value of it, and let them make the decision. So the idea of inflammatory testing to understand, is your treatment effective? Let's hypothesize. You had a heart attack a year ago. You're on the standard treatment. Your cholesterol looks fine, your blood pressure looks fine, and you want to know if you're okay. Well, really, you need to know the inflammatory state of your vascular system to know that your treatment is adequate to mitigate that disease. And then the third thing, I really think, if you're asking me three things, genetics, inflammation, and the third would be some ability to monitor the disease over time. So just wondering if the arteries are healthy is very sketchy, because you don't feel a problem until you have a problem. So we really like the idea of clinicians across the country, in all specialties, by the way, to absorb the idea of looking at the artery wall through ultrasound. And we use the carotids, the femorals, the aorta. We use all kinds of things to peek in the body and say, hey, are your arteries healthy, or are they showing vulnerability? So those are probably, if you ask me, my top three, probably the top three things I wish were embraced more readily.
So genetics that are valuable provide valuable information, and many of them actionable, if you will, make a difference today in your life. And then the inflammation panel, which we'll go into in a future date, but there are at least 4 that are very specific about inflammation that drives atherosclerosis, or the vascular disease process.
Correct.
And the ultrasound, looking at the arterial wall, as was demonstrated in Johns Hopkins, the study evaluated at Johns Hopkins. Yeah.
You know, one thing I just want to mention to that, on the heels of this discussion being women's heart health, while the American Heart Association and the Red Dress campaign has done a tremendous job to try to increase awareness, a lot of the individuals who are speaking on behalf of the American Heart Association are so generous as to share their story, but a lot of their messaging has to deal with early recognition of symptoms. If you have symptoms, don't ignore them, get in, and that's terrific advice, and I'm not discounting that at all. But what I like the idea is to challenge that just a little bit further and say, gosh, wouldn't it be nice if you knew you had disease and you treated the why of that disease and saw the inflammation go down and saw the disease stabilize, so that you never had symptoms in your life? So the idea of backing up this train to even before symptoms, don't wait for symptoms, because by the time we have symptoms, the horse is out of the barn. That disease has already misbehaved. So I just want to challenge people a little bit to think well even before what they're comfortable with, and know that the science is there. And one thing that I've always said is atherosclerosis, the disease of the arteries, is much smarter than the technology that's been historically designed to find it. Because the technology that's been historically to find this stuff looks at blood flow, whether it be a stress test or an angiogram. What we're talking about is finding it early, why it's still hiding in the artery wall. And then when we find it there, we ask why. And then the why question is really looking at these plethora of root causes, which over the years we've gotten better at it. We've gotten more understanding, and we haven't yet a lot to learn yet. But you know, root causes like, of course, lipids and blood pressure, those are already recognized, in nicotine, we know that. But the things like lipoprotein A, insulin resistance, gut dysbiosis, periodontal pathogens, unknown endodontic lesions, all of these things that are going on, and the poor person has no idea that there's a connection. So part of this is education. Actually, 99% of it is just education.
Yeah, that's so good. And you know, we have many examples. For example, we often talk about, and let's just take a few minutes and talk about Bob Harper. Let's talk about Susan Lucci. And there are many others, of course, high profile people that have had incidents of heart attack, Bob Harper heart attack, and Susan Lucci stenting. And so talk a little bit about that. I know you've written some blogs on it. Elaborate on a couple of those stories for us.
The first thing I'd like to do is just publicly send my gratitude and respect to these individuals that are willing to be vulnerable to save other lives. And I feel that way about, if we're talking about Bob Harper or Susan Lucci, because they may not know it, but their discussion on their own personal medical history is going to save so many people, and I'm extremely grateful for that. Let's talk about Bob Harper first, because it's one that frustrates me, to be honest. When Bob Harper got on that treadmill that day at the gym, he got on that treadmill justified that he had all confidence that he was going to be able to get on that treadmill, he was going to exercise to complete exhaustion and get off and go home and have a good day. And the reason he had that justification is because he was told time and time again at his annual physicals, and this is a gentleman paid to be healthy. He is paid to train other people to be healthy. So you know for a fact he had optimal standard of care, which said you do not have a blockage, you are healthy, your cardiovascular risk profile is low. So imagine and appreciate his shock when he's on that treadmill and cannot breathe and drops from a heart attack. Fortunately, his life was saved, and I'm so grateful for that. Cardiology did at that time what they needed to do, which was save his life. But what happened was, what Bob Harper taught us afterwards is there are so many root causes, or I shouldn't say taught us because we already knew, but validated what we've known for so long, and that is there's so many root causes that are missed in the traditional workup. And in his case, it happened to be something called lipoprotein A. Brad Bale and myself have been measuring lipoprotein A since the year, I think 2000, 2002 for sure, because it has been validated for over a decade that in 2000 and right before 2010, it was 2009, Dr. Michael Lauer, who at the time was the president of the National Health Lung and Blood Institute, said, look, this abnormal genetically inherited lipid abnormality causes heart attacks. Measure it and check for it. And yet here we are in 2019, and it's not part of a standard workup. Mm-hmm. So I could talk for hours on the politics and the reason that is, but the point taken, if someone is knowledgeable that they should get checked for this, then if they are checked for it, is a treatable condition. And so part of my frustration is we don't know what we don't know. So I appreciate Bob Harper and his sort of push with the Lipoprotein A Foundation and his quest to get people educated. The irony is things are going to change, and they're going to change at a more rapid rate because he is somebody with a strong voice. Mm-hmm. And I'm glad about that. The Susan Lucci situation, you know, a couple things on her. One, I think the biggest lesson we can learn from Susan Lucci is not only how amazing she is and how gracious she is, and my respect for how she handled this is tremendous. But also when you look at her, it's similar to Bob Harper. People who look at someone like Susan Lucci say, oh, she is exactly how you define health, which she is for a lot of reasons. She's a non-smoker. She has prided herself into being healthy and staying healthy, gotten regular physical exams. Why was it that day that she was shopping and had these symptoms of chest pressure and couldn't breathe? The reason was she had plaque growing silently in her arteries for years. And no one knew it because no one looked. And the perception might be, well, it would be too expensive to do that. I mean, not everyone has resources to go look. These tests, Gina, are about $100. We're not talking big tests. And so if people understand that they just need to ask for it, it's available. And one of the things that brings me to our book, on why we wrote it. We wrote a book with a co-author who's tremendous. Her name is Lisa Collier-Cool. And I will publicly announce on this 2019 that we're in the process of writing a second book, and we're excited about The premise is going to be the same in that we feel very passionate that patients, the healthcare consumer, needs this information because it's the healthcare consumer that's ultimately going to change the paradigm of care, meaning they're going to demand better. And so when we wrote our book, that was a long discussion we had. Who are we writing this for? Are we writing it for the medical public? Well, yes, of course we are, because they're the ones who actually have to order the tests and do something about them. But we felt, based on the sheer statistics and massive death rate and recidivism rate of this disease, that we needed to get something out for the public to gain knowledge. And if the public gains knowledge and has the resources to do something about that, meaning we put all the resources in that book for them to take it to their doctor and say, hey, I want to be trained. And if that nurse practitioner, physician, cardiologist says, oh, well, tell me more about this, then they will equally get educated. So we hope that it's been a little engine that could. It keeps going and going and going. It's been reprinted several times because the patient demands it. I mean, that's what we have found.
Excellent. And I'm thrilled to hear that a new book is coming.
Yes, it is.
That's wonderful. The current book, Beat the Heart Attack Gene, by Drs. Bradley Bale and Amy Doneen. If you don't have the book, you'll definitely want to read that and know that a follow-up is coming soon.
Yes.
I hope soon.
Yes.
The other thing that I wanted to comment on, based on what you just said, is the fact that you mentioned that the disease is smarter than the technology that we have to find it. And most people think that a stress test is the technology to find it. And if you pass a stress test, you're fine. We spoke about that a little bit earlier. You can be fine today and not tomorrow, like Bob Harper, like Susan Lucci. And the study that we learn about in the preceptorship, it's well known in the literature. We currently know without a doubt that in the United States, 38% of us have atherosclerosis. We call it subclinical vascular disease. Subclinical meaning there's no symptoms yet. Maybe I look fit, maybe I don't look fit. Whatever you look like, whatever your lifestyle, you're having no symptoms. And so you assume that the arteries are fine. Maybe you even pass a stress test and you assume your arteries are fine. However, subclinical atherosclerosis could be present, and it could be in a stable form, or it could be, as you said earlier, the lipid-rich form that is more dangerous. And if you don't look, you don't know. That same study made a projection that by 2035, that 45% of the population would have. Yeah, almost half of us walking around feeling fine today, but who knows what'll happen later today or tomorrow if you don't know the state of the health of your artery, which, is you've already so eloquently described, is simple, easy, and cost-effective to do. So looking back, we wish Susan Lucci, we wish our friends and neighbors and loved ones who have been succumbed to the disease by either presenting with the worst case of the first symptom, which is sudden cardiac death, as unfortunately many people do. Don't let that be your first symptom of knowing that you have atherosclerosis, but certainly it can be chest pain and it can be heart attack. But anyway, we wish that they would go and get an evaluation to look at those arteries, look at inflammation, look at genetics.
On that, I just want to add one thing to what you said, because it's really important what you said. When I have the opportunity to see patients, which I see patients regularly, and I have the honor to meet them for the first time, I always ask them what their definition of optimal health is, because ultimately I'm there in partnership with them. And of course, they're coming to me to seek cardiovascular prevention advice. And I ask them, what is your goal of optimal health? And some people may say to me, look, I'm going to go climb Mount Everest. Or some people say, I just want to be independent my whole life. I want to drive my own car. I want to open my own door. I want to be independent. Some people may say to me, my goal of optimal health is that I'm never on a medication, because if I'm on meds, I'm not healthy. That's what they might say. So one of the challenges I always offer to my colleagues is find out first what your patient's desires are, and then use the education that we have with how sneaky atherosclerosis is to educate them to also meet their needs. I'll give you an example of that. For someone who says to me they want to live independently, which is by far and above the majority of responses, what they're ultimately afraid of are the diseases of aging, such as microvessel disease of the brain. We call it dementia, right? Or microvessel disease of the kidneys, which requires people end up on dialysis for the last 5 years of their life. No one wants that. Or we call it diseases of the eyes that claim arterial blood flow to the eyes, claiming vision early on. Or it's called a heart attack, or it's called a stroke, or even peripheral vascular disease. So the idea of cardiovascular disease prevention is more than just the heart or the brain. So when we look at historical modalities to find out our cardiovascular risk or our desire to live well forever, the technology has been designed to look at blood flow. And as you so perfectly stated, we don't know there's a blood flow problem until we do. And the technology that we have right now allows us to find this disease at its very earliest stages, and that's when it's virtually out of sight, out of mind, hiding in the artery wall, not presenting itself through the blood flow. So one of the things that we have advocated for years now is simply give the patient the opportunity to find out if they have silent atherosclerosis, and then pause and ask the why. And it's a pretty simple equation. You know, if you have vascular disease, you measure the inflammation, you figure out why it's there, and there can be lots of root causes. Then in reverse, you treat the why, you see the disease or the inflammation go down, and you see the disease stabilize. That's a pretty simplistic approach on a complex disease state, and we have to do it because the current system is allowing those statistics to continue. And it just has to stop. It's just crazy. It's a preventable condition.
Preventable condition. If you don't look, you don't know.
Yeah.
Yes, along those same lines, let's talk about, and I know this is going to be in the new book, it was in the previous book, but I'm sure it will be elaborated on. This new definition, it's not really new to us in the BaleDoneen Method community, but it may be new to a lot of people that haven't heard about the BaleDoneen Method before. New definition of prevention, meaning historically, we've had two categories. So when you go to see your nurse practitioner or your physician, they'll do whatever their protocol is, if you will, or their method of prevention tests, and determine that you are primary prevention or secondary prevention. And you would be in a primary prevention category if you had not had a heart attack, a stroke, stent, bypass surgery, and they may have done a stress test, passed it, may not. But either way, you would be in that category. Then you present, like we've just talked about Bob Harper or Susan Lucci, and you have chest pain, and lo and behold, you have coronary artery disease and you get a stent, you're moved to secondary prevention from that point forward. Bob Harper would have been moved to secondary prevention, presenting with a heart attack. Elaborate on the three categories of prevention that are actually more accurate.
Sure. I'm going to use aspirin as just an easy, tangible example of what I want to articulate.
Okay.
So historically, and even today, standard of care, which is the American Heart Association, the American Medical Association, all the trials we read place us in a binary system. That binary system is just as you said. You have had an event or you have not. The question then becomes, for those people who have had a heart attack, the decisions sometimes become easy. Yes, you need to take a baby aspirin, but for this category, people are left to wonder. And most recently, there were 3 trials that challenged that idea. Gosh, if you're in this binary approach where you have not had a heart attack yet, should you take baby aspirin? Well, what we are proposing and what we always have proposed is challenge that concept, and let's migrate from a binary approach to a ternary approach, which means we're going to divide people into 3 categories. Category 1 means you have not had a heart attack or stroke, and we have looked, but we cannot find any plaque in those artery walls at all. We call it a cat in the gutter, and I'll go into that in a minute, but there's no plaque there. Secondary prevention in our definition means, yeah, you've got some disease and inflammation in that artery wall. It's never misbehaved, and it's our lifelong goal to make sure that doesn't happen. And tertiary is easy. Those are the people like Susan Lucci or Bob Harper, who've already had an event. And if we knew if we were in one of those three categories, oftentimes the treatment decisions become so much easier. So people who need baby aspirin are people who have plaque in their arteries. So that's secondary or tertiary. And these people, hopefully, we want to keep them medication free. So it's migrating from a binary approach to a ternary approach. And with that just simple definition of walking in an office, it demands immediately that we look for the presence of disease. And it doesn't mean look for it by a stress test, because a stress test is only going to be abnormal if you have about a 70% blocked vessel. However, 86% of heart attacks occur in vessels that are less than 70% occluded. So we need to do better. We need to look for plaque hiding in this artery wall here, because that's where we'll find it at its earliest stages.
Absolutely. One last question, and that is, if I were a new nurse practitioner just starting out my career, or maybe been in practice for a little while as an MD, what would your message to me be? I know that we need all hands on deck, if you will, in this battle against cardiovascular disease, this war on these terrible disease that's taking out our population, according to David Wright, at the numbers congruent with what, 5 to 7 747s?
Yeah, it's a great analogy.
Nonetheless, we need more healthcare providers that are committed to this BaleDoneen method and this type of prevention work. What would you say if someone came to you and said, give me career advice?
Yeah. Well, I'm biased because I think that we're all responsible for this disease state called cardiovascular disease. And my biggest piece of advice would be, remember, we're all responsible for it. We don't go into family medicine and think we're not responsible for cancer prevention. Right. If you're in family medicine, you're going to order the mammograms and the prostate exams and the chest X-rays. You're going to do the skin checks. You're going to do the best you can for cancer prevention. The challenge has been that no one has claimed the specialty of cardiovascular disease prevention. It has somehow been inappropriately placed upon this already full schedule of cardiology, which are doing a phenomenal job saving lives. They are catching people after the fact, but what we need to do, if I'm a nurse practitioner, if I'm a family practice, or if I'm an internal medicine doc of any variety, or pediatrician for that matter, psychology, I don't care what the specialty is, realize that this is the most common cause of death and disability for all of our patients, no matter what specialty we're in, and we need to do a better job, and we need to work together. We need to knock on the door of our dental offices and say, hey, I need your help. I need to know if there's any inflammation coming from the oral cavity, and I hope at some point to come back on your show, Dr. Pritchard, and do another talk on just the importance of nurse practitioners and physicians to be talking to the dental hygienists and the dentists. Like, we need to collaborate, and I'd love to come back and talk to you about that sometime. But if I was to give advice, it is to say we are responsible for cardiovascular disease prevention, period. And there's tools and training and techniques, and our method is designed for that, and it actually works. Right. And that's not an opinion, that's the science talking.
Yes. Love it. And another topic that we'll have to bring you back on to talk about is, we haven't had a chance on this episode to go into the business aspect of it, but it is the most rewarding type of practice that I've ever been a part of. Truly seeing a difference in the lives of your patients, being able to take the time that you need to with your patients. It certainly has been and can be for others financially rewarding. So it has the opportunity to meet all of the goals that most of us really wanted when we first started out, to spend time with our patients, truly impact their lives for the better, and make a decent living doing it, right?
Mm-hmm, for sure.
Yeah.
For sure.
So thank you so much. It's been wonderful to get to know Dr. Amy Doneen a little bit better. And I'm sure we'll have you back on, because a lot of people are going to want to know more. Of course, because you're the co-founder, one of the co-founders of the method. So thank you so much for this time today. Any closing thoughts?
No, I just appreciate you spreading the word, Dr. Pritchard. You are definitely a thought leader in the country, and it's a real honor to be on your show. I appreciate it, and I hope that as people listen to this, really take a sense of responsibility on this disease state, because if you don't do it, no one else is. And I think that's part of it. Everyone thinks it's someone else's job, and ultimately it's your job for the health of your patients to do better.
Absolutely. Absolutely. Well, we'll hear more from Dr. Amy Doneen on future episodes. So if you haven't subscribed to our YouTube channel, please do, the BaleDoneen Method on YouTube, as well as in the link below. And also sign up for our podcast distribution so the notifications come to your phone or come to your inbox so you don't miss a single episode. And Dr. Amy Doneen will be back on in the future. So thank you, Dr. Doneen.
Thank you so much. Thank you.
Bye-bye.
Bye.